slightly the odd one out this afternoon, but I would like to take things a little bit more philosophically and to try to run through with you whether endometriosis really causes infertility, because we are all aware that it is one of the possible diagnoses that we make in a patient with a fertility problem. I do not have any significant conflicts of interest. So the assessment of causation is slightly more difficult or more elaborate, if you want, than just normal association. It is the difference between what you would find in a patient with lung cancer if you would say the association is there with smoking, but there is also an association with having a lighter in your pocket. But obviously a lighter in your pocket does not cause lung cancer, it is merely associated with it. So to have a real causal relationship between two things, you need to ask more questions than just the association. There is a lot of literature on this subject, but I would like to condense it into 5 main questions regarding the relationship between endometriosis and infertility. Namely, the type of association, if there is a temporal relationship, if there is a dose-response gradient, the sense of the association, does it make sense or not, epidemiologically and biologically, and also the effect of removal and reintroduction. First of all, the type of association. There we can ask ourselves 3 main questions. Is there evidence from true experiments in animals or humans that endometriosis is causing infertility? If there is an association, is it strong? And is it consistent in different situations? So when groups are more comparable, can we still find the same association? So on the type of association, does induction of endometriosis, if you would do a true experiment, induce endometriosis in a patient? Obviously, this is not possible, this is unethical, so clearly we have no data. But there are some animal studies that have looked into this. Looking into animal models on endometriosis is a whole discussion on its own, but I think that you may be aware that the only animals who have naturally occurring endometriosis are the non-human primates. So that would be a good model not only to look at spontaneously developing endometriosis, but also on the effect of inducing endometriosis. Of course, this type of studies do generate some ethical considerations, and also there endometriosis might be a confounder. Rodent models are often used for investigating endometriosis, but not necessarily on their true effect on the fertility potential of the animal. So I think from the animals type of studies, there are some prospective cohort studies not necessarily induced, mainly on spontaneously occurring endometriosis. We'll come back to that later. There are some arguments that endometriosis is associated with infertility, especially the more extensive cases. Is the association strong? Does it stand through different areas? If you look at the prevalence of endometriosis in the infertility population, again, going back to the animal studies, and we see in older studies from Sadova that the monthly fecundity rate and clinical pregnancy rate are lower in spontaneously developed endometriosis, and as I said, mainly in the stage 2, 3, and 4 problems. So in the later stages, stage 1, data are similar with animals with non-recurrent. If you want to look into human data, what would you ideally want to observe? Ideally, you would prefer to have a large prospective observational cohort study where you would compare 2 groups of patients, one with endometriosis and one without endometriosis, even maybe prior to attempting pregnancy, not only to see whether they do develop an infertility problem or not, but also how extensive it is. And those patients, they should be similar regarding to age, BMI, and any other infertility related factors. So this is, I think, it hasn't been done. It's quite difficult, even impossible, and probably also unethical in different aspects. So we have to work with what we know as the prevalence data, and I think we are aware again that the general prevalence that is usually used to define endometriosis in the normal population is somewhere around 10%. So if we would find in infertile patients that the prevalence of endometriosis would be higher, then that could in itself be an association, or that would be supporting the association between endometriosis and infertility. Obviously, we will have confounders when we look into that, because we will have a selective use of laparoscopy in the infertility investigation. Clearly, not all patients will have a laparoscopy. We will therefore have a varied patient recruitment, and even in women without infertility problems, if you want to have a true control population, you would even less use laparoscopy to detect endometriosis. So in the older comparative studies, the control group mainly consists of women who undergo laparoscopic sterilization, and then the prevalence of endometriosis is described. But of course, when you do laparoscopic sterilization, you do not maybe necessarily try to look for any type of endometriotic lesion, especially the subtle lesions, and maybe you also don't really ask for a pathological confirmation. So this might not be the ideal control group. But I do think there are data, so mainly older studies, and when you look into the prevalence of endometriosis in patients with laparoscopic sterilization, you can clearly see that the prevalence is quite a lot lower than the studies that describe laparoscopies in infertile patients, which are around 33%. So the prevalence of endometriosis in a subfertile population undergoing laparoscopy is around 30%, depending on which studies you look at, 20, sometimes even 68%. We ourselves have done a few years ago a retrospective analysis in women specifically selected with not only undergoing a laparoscopy because of infertility, but also who appeared on other studies, on other investigations, to have a normal ovulation, normal sperm sample of the partners. And there we could find in almost half of the patients endometriosis, and 2/3 of these endometriotics were of the lower stage, so the stage 1 and 2. So there you could conclude that if you select your patient group even more than just having a fertility problem, but try to select it as much as you can, then you might have even a higher prevalence of endometriosis, which supports again the association between endometriosis and infertility. Is the association that we find, is it consistent? Is the effect consistently present in different settings? And in that respect, I would like to focus most on controlling for the type of conception. You can have either spontaneous conception, medically assisted reproduction, and all its variants. So on untouched endometriosis, looking into what it does on spontaneous conception, again, mainly older data suggest that there is a reduced spontaneous fertility rate, monthly fecundity rate, and cumulative pregnancy rate, but those studies are not always controlled. This is again a retrospective study where laparoscopic diagnosed but untreated minimal to mild endometriosis was performing worse than when compared to unexplained infertility, so a negative laparoscopy, if it was not treated. Another interesting patient group, this is an interesting article, even though it is quite small, it shows on data on patients who are actually waiting to start ART and who have different reasons why they are infertile. And then you can see that the chances that they will have a spontaneous pregnancy while waiting on the ART is less when they have endometriosis than when they are having unexplained infertility. So again, an indirect argument to say that endometriosis is involved in infertility. In the situation of IUI, also quite older studies, not always very good control if you look at the untreated, and we want to compare them with unexplained, but the data that we do have seem to be telling that when the endometriosis is not treated, that patients seem to perform worse than when the laparoscopy has been negative. think one of the previous speakers has already touched on the effect of the endometriosis on ART outcome. You are probably all aware of the older meta-analysis of 2002 of Barnard, which is much cited. And then again, also as Professor Well has just explained, the large databases, which show enormous amounts of patients, enormous amounts of ART cycles. But the problem is that those data are also fairly uncontrolled. So it's still difficult, even though it appears that patients who have endometriosis do not necessarily perform in these databases really bad at IVF. I think you should, balance that out with the fact that you don't exactly know what they're comparing. Then again, also the two most recently published meta-analyses on the same subject, one by Hamden and one by Harp. I just want to because they have slightly different outcomes that they report on, just to put them next to each other. If you look at what patients they look into, endometriosis per stage versus no endometriosis, obviously, but not all patients will have had a laparoscopy, especially those without endometriosis. So this is an important confounder. The fertilization rate in this Harp meta-analysis seems to be reduced in the lower stage endometriosis. The implantation rate appears to be reduced in the same meta-analyses in the higher stage endometriosis, and clinical pregnancy rate in both reviews is lower in stage 3 and 4 endometriosis. There is a trend for lower, I think this is there's a trend for lower live birth rates in the Harp meta-analysis, and the other meta-analysis 2 years later, they truly found a lower live birth rate. So this is, again, suggesting that patients in IVF or in ART may perform worse than other patients when, with all the limits that we have with the methodological interpretation of these data. The second question, temporal relationship. This is a very difficult question to answer because what this essentially means is that you see the longer the endometriosis exists, the higher the effect would be or should be on the fertility. And this is something we just don't know. And is this, as you are all aware, infertility is strongly related to age. So the longer you wait, the higher the age effect would be. So we don't have very direct data to conclude that there is a true temporal relationship between endometriosis and infertility. The third question, the dose-response gradient. If your endometriosis is worse, do you then have more infertility? And I think this is where we have made, maybe as fertility specialists, our life slightly more difficult than we should, because we have classification that everybody sticks to, which is the ASRM or AFS classification, 4 stages, you all know them. But it's actually not a very good classification. Even the ASRM committee agrees that, unfortunately, no staging system correlates well with the chance of conception following therapy. So we may need to rethink the classification system to have a more dosage effect, let's say, to extract that more about from the data. There is also something like the endometriosis fertility index, which has been shown to be correlated with pregnancy rate, non-IVF or non-ART's pregnancy rate after surgery, but this is obviously post-operative and after treatment. So again, we don't have a good classification system to quantify the amount of endometriosis and see if whether you have more endometriosis, you would have more infertility. The sense of the association doesn't make sense. I think we all know that there are a lot of pathological and pathophysiological studies on the mechanisms behind endometriosis and infertility. Just to summarize these, one important thing is the mechanical factors, so distortion of normal anatomy, especially in severe cases, hampering a normal tube ovarian contact, causing sometimes abnormal ovulation, even destruction of ovarian tissue, not only by the endometrioma but also maybe by the surgeon. Having an inflammatory pelvic status might cause some type of toxicity of the peritoneal fluid and may influence or may not, as we heard before, egg quality and follicular genesis. Having an impact on the receptivity of the endometrium, luteal function. Adenomyosis here might be quite a strong confounder in implantation. And last but not least, pain. Patients who have a lot of pain, especially in deep endometriosis, and if they have pain during intercourse, they will probably have less sexual intercourse than a patient who does not have pain, and that indirectly may have its own effect on chances of pregnancy. The last question, the effect of removal. What if we treat endometriosis? Does it improve infertility? Obviously, we will again first have to have made the diagnosis. So to select a control population, also to select a population is not always easy, and also to perform a study where you, in one half of the patients you treat them, in the other half you don't, nowadays would be quite a difficult study. Apart from surgery, also hormonal therapy for endometriosis. I think the ESHRE guidelines are quite evident that you should not prescribe hormonal therapy. But the effect of surgery on starting with the stage 1 and 2 endometriosis, the more recent analysis, Cochrane analysis by Duffy et al. 2 years ago, concluded that there is moderate quality of evidence that laparoscopic surgery to treat minimal endometriosis reduces overall pain and increases both live birth rate and ongoing pregnancy rates. So this is why this is also in the ESHRE guidelines, that in case you do laparoscopy on a patient who has stage 1 or 2 endometriosis, you would rather be performing a surgical treatment than just making the diagnosis, since there are arguments that this would improve the spontaneous fertility of the patient. Things get a little bit more difficult when you look into stage 3 and 4 endometriosis. Looking into the effect of infertility reporting, or fertility outcome reporting after surgery, we see that only a minority of the studies report these, and you have a lot of mixed populations, patients with pain, patients with who do not have fertility, who they still report partially on fertility, maybe later, maybe not everybody wants to become pregnant immediately after surgery. So we don't have any strong randomized data on the stage 3 and 4 endometriosis. So more research is definitely needed in that area, especially in patients who are asymptomatic, I think. And that's why it is stated in the ESHRE guidelines that you could consider operative laparoscopy instead of expected management in these types of patients to increase spontaneous pregnancy rate. The effect of the removal of endometriosis. I've just been talking about natural pregnancy, spontaneous pregnancy. Does it increase the IUI chances if you treat the endometriosis prior to IUI? Again, here we do not have very strong arguments. There are a few studies. One is the Werbrook paper, which is a study from our group from 10 years ago, where we have looked into the cumulative pregnancy rates after IUI in patients who had a laparoscopy for minimal to mild endometriosis, and there we found that when it was treated in that group, the patients had similar pregnancy rates than those with a negative laparoscopy. In ART, you will not find RCTs to look into this, so ART outcome and what the effect would be on of the surgery on the outcome. But I would like to point out one very interesting study of Orboinen. They did a very large retrospective analysis. It is retrospective, but it is quite large, where almost 400 patients who had surgery for the stage 2, stage 1 to 2 endometriosis were compared with 260 patients who just underwent the diagnostic laparoscopy. And then they saw that in the subsequent infertility treatment, ART treatment, patients who had removal performed better in IVF. I think this is not strong enough to recommend a diagnostic and/or therapeutic laparoscopy for peritoneal endometriosis in any patients who undergoes IVF, but I think it's something to keep in the back of your mind, that it might be, especially in a patient who has pain and who has another indication for IVF, it might be interesting. On the stage 3 and 4 front, we have more conflicting data, no strong arguments again prior to surgery. So I would like to conclude, when you sum up all the questions and their answers, apart from the fact that we don't have data on temporal relationships, and there are some questions where it is just impossible to have an answer because of ethical reasons, mainly they all tick yes. So I would still conclude after all this that endometriosis does cause infertility. Thank you for your attention.